I think it's taken for granted in school when we learn about certain conditions and dosing and frequency and route of administration. Those things aren't really emphasized because they say that you're going to learn these things when you start working. But it also makes work very difficult when you don't really know the dosaging, you don't really know the frequency, you don't even know the route of administration. You end up mismanaging patients and you end up giving the wrong dosages. That's why it's quite important to actually have a thorough understanding of these drugs, a thorough understanding of these dosages, and a step-by-step guide to help you through the management of certain conditions. Today we talk about one such condition. Grab your piece of paper, grab your pen, and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at hypertension management, a step-by-step guide. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend, we are doing lectures on the channel. So I won't even go into details about talking about hypertension and what it is, the different causes, investigations. I'll jump straight into the management. So if you are watching this for the very first time, I have another video on hypertension that I will leave tagged at the end. Please head over to that video and it will help you understand the other concepts on hypertension. So when it comes to the management of hypertension, we are splitting it into two main halves. We are splitting it into non-pharmacological management and pharmacological management. And take note that this is outpatient management. It's not management of patients that are going to be coming in with hypertensive urgency. It's not management of patients that are going to be coming in with hypertensive emergencies. I'm going to cover that in a separate video on how we could manage those patients. This is strictly just patients that come in with hypertension, the newly diagnosed hypertensive patients. So it's divided into two broad categories. So those that are going to be managed with non-pharmacological means, this is just lifestyle modifications, and those that are going to be managed both with non-pharmacological means and pharmacological means. But you must strive at all times to educate your patients on non-pharmacological management of their conditions. So the goal is to reduce the blood pressure to less than 140/90 if they don't have any other comorbidities. But if they have comorbidities like diabetes, renal disease, and cardiovascular disease, you want to drop it much lower to less than 130/80 to prevent risk factors. So patients that have stage 1 and stage 2 hypertension should be counseled on lifestyle modifications. If they have end organ damage, you should start them on medication as soon as possible. But of course, with also these lifestyle modifications. And what are these lifestyle modifications? Salt restriction. So intake not more than 2.4 grams of sodium or 6 grams of sodium chloride. It's quite difficult to measure the amount of sodium that a patient actually takes in a day. So the advice that I usually give patients is that avoid adding extra salt over the table. The salt that you must take is what was added to the food when it was cooking. The second thing is that they should have a low salt or low sodium diet, and they should have what is known as a DASH diet, dietary approaches to stop hypertension. So they should eat diets that are rich in fruits, vegetables that are low in fat, dairy products that are low saturated fats and have low unsaturated fats and low levels of cholesterol in essence. Then they should also reduce their weight. Ideally, their BMI should be between 20 to 25, so that calls for need for exercise, of course within their limits. Aerobic activity, for example, a brisk walk for 30 to 45 minutes most of the days of the week, so like 3 to 4 times in a week. They should decrease their alcohol consumption to less than 3 units per day for men and less than 2 units per day for women. And of course, remember that alcohol is going to potentiate the catecholamines and it's going to exacerbate hypertension. If they do smoke, you tell them to stop smoking. You can also advise them to take up some stress relaxation techniques. For example, getting some leave days from work, going for some vacations, doing yoga and meditation, those kind of things. Then for patients with mild to moderate hypertension, they can actually be given 3 months trial to see if the lifestyle modifications have worked. But that's assuming that they don't have any target end organ damage, because if they do, then you have to treat them, because the target end organ damage is going to keep progressing if you don't address it. Then, of course, if the brief trial of the non-pharmacological therapy fails, then you continue doing it and you keep adding medication to their regimen. Then those that have stage 3 or severe type of hypertension, and those that have complications like stroke, chronic kidney disease, coronary artery disease, congestive cardiac failure, retinopathy, those must be treated with antihypertensive medication. And then other modifiable risk factors such as diabetes, hyperlipidemia, smoking must also be addressed. They must also be treated. And remember that patients should be counseled on antihypertensive medication. The patient must take their medication every single day, preferably at the same time, for it to actually reach the maximum working dosage, or to have this maximum therapeutic dose or rather a therapeutic dose in their bloodstream. So even if they don't feel okay, they should take their medication. If they feel okay, they should take their medication. And they shouldn't just stop their medication without seeking the consult of a doctor. And if they're experiencing any side effects, they mustn't stop taking the medication, but they must seek medical help as soon as possible, so that a doctor can actually intervene or change the medication in case of it being an adverse reaction to certain drugs. So I'll talk about the common drugs, and I'll include the dosages. Then I'll give you a step-by-step guide of how you can actually use these drugs and combine these drugs to effectively manage your hypertensive patients, especially in the outpatient department, or even patients that are newly diagnosed that may be admitted to your ward. So I like to use the ABCs. So A for ACE inhibitors and angiotensin receptor blockers, B for beta blockers, C for calcium channel blockers, D for diuretics. So we'll start with the ACE and E blockers. Remember that these ones are going to be blocking the enzyme angiotensin converting enzyme. And remember that this is an enzyme that basically catalyzes the conversion of angiotensin 1 into angiotensin 2. So it blocks the formation of angiotensin 2, which is a potent vasoconstrictor. So if you don't have this, the renin-angiotensin system is often blocked. And so another function of this is that it's going to be blocking the breakdown of bradykinins into inactive compounds. And remember, bradykinins are a potent vasodilator. This is a very, very important thing, because one of the major side effects of these is a cough, a dry cough. So patients that have asthma, you should use these drugs with caution, because it may cause a dry cough. Patients with COPDs, you should use this drug with caution, because you block the breakdown of bradykinins, and bradykinins begin to accumulate. They may cause angioedema, they may cause a dry cough, they may sometimes even cause swelling of the different parts of the body. I remember dealing with a patient this very past week that had ACE inhibitor intolerance. Then there is evidence that blacks actually have little levels of renin in their body, and they actually respond not so well to ACE inhibitors as opposed to them being combined with diuretics. So if you want to use ACE inhibitors in black individuals, then you generally want to combine the ACE inhibitors with a diuretic to get a maximum benefit. And remember that these are going to be beneficial for diabetic patients, especially those that have nephropathies, because they're going to slow the progression of the disease. At the same time, they are very beneficial for patients with symptomatic and asymptomatic left ventricular dysfunction, because the ACE inhibitors have been actually noted to improve the survival rates of patients with cardiac disease. Then, of course, there is a profound hypotension that may be seen with the first dose. This is very common, especially with enalapril. So this is occasionally seen in sodium-depleted patients and in those that are on treatment with large doses of diuretics. So you should actually look out for this, that a patient, after you give them the first dose, you may drop the BP way too quickly. And remember, if you drop it too quickly, organs can begin to be underperfused. Then with the ACE inhibitors, generally those that have renal failure, also you want to use them with caution. Or those that have renal dysfunction, you would actually use the ACE inhibitors with caution. If you do use them at a much lower dose. And remember that the renal function must be monitored, as deterioration can occur in patients with severe bilateral renal vascular disease. In those that the production of angiotensin 2 is a major role in maintaining the renal perfusion. So if you block this, you may actually further cause much more harm in the kidneys than you were supposed to cause good in this patient. So what are some of the indications and contraindications? So indications, those that are below the age of 55 years old, Caucasians, those that have heart failure or left ventricular dysfunction, myocardial infarction or cardiovascular disease, diabetic nephropathy, chronic renal disease, stroke secondary prevention. ACE inhibitors are a very, very good start to actually use. Contraindications, like I said, patients with renal failure. So you should make sure you monitor your electrolytes, you monitor your urea and your creatinine. Then with peripheral vascular disease, if they have renal vascular disease, and also these are contraindicated in pregnancy. Most of the usual drugs that we use in non-pregnant women are often going to be contraindicated in pregnancy. So there are a few drugs that you can use, like methyl-dopa. I won't talk about it in this lecture. And also other drugs like hydralazine. Also other drugs like beta blockers can be used in pregnant women, but generally you want to avoid ACE inhibitors in pregnant women. So here's an example. So enalapril is a drug that you're going to commonly see and commonly prescribe. So the dose is between 5 to 40 milligrams orally daily. So you can start at a much lower dose, especially if they have renal impairment. You may start at 5 milligrams. And if you're combining it with a diuretic, you may start at 5 milligrams or then keep increasing it. And remember, the maintenance dose is 20 milligrams once a day. You shouldn't exceed 40 milligrams a day. That's the ceiling dose. That's the maximum dose. So if you have maxed out enalapril and a patient is taking 40 of enalapril in a day, and their blood pressure is not being controlled, then that's an indication for you to add a certain drug or a second drug, because it may not be sufficient enough to control the blood pressure to the optimal levels that you want. Then moving on to the angiotensin receptor blockers, which can be used as an alternative to those patients that have ACE inhibitor intolerance, or those that develop side effects, because angiotensin receptor blockers are not going to break down bradykinin, so they're not going to cause a dry cough. They're not going to be causing the angioedema as compared to the ACE inhibitors. So these can be used as an alternative. And they also do cause angioneurotic edema and even renal dysfunction, but not as much as the ACE inhibitors. Then indications are going to include things like ACE inhibitor intolerance, patients less than 55 years old, Caucasians, hypertensive patients with left ventricular hypertrophy, heart failure or left ventricular dysfunction, myocardial infarction, diabetic nephropathy, chronic renal disease. And remember, just like with the ACE inhibitors, avoid them in renal failure. So you should monitor the electrolytes, urea and creatinine. You should actually avoid them in peripheral vascular disease, especially if they have evidence of renal vascular disease. Avoid them also in pregnancy. I once saw someone actually combining ACE inhibitors with angiotensin receptor blockers. That does not make any sense. We don't combine these two drugs, and they shouldn't be combined because their mechanisms of action are very similar. The angiotensin receptor blockers block the functioning of angiotensin 2. Then the ACE inhibitors usually block the function or the production of angiotensin 2. So it's kind of like you're giving two drugs that are working on a similar system or on the same system. It doesn't make any sense. So they shouldn't be combined. Then examples of two drugs that you commonly see is losartan and telmisartan. So you can actually get these as a preparation on their own, losartan on its own and telmisartan on its own, or you can combine, or they can come as a combination with hydrochlorothiazide. So you may have losartan and hydrochlorothiazide, which you commonly see as losakind. You may also have telmisartan with hydrochlorothiazide, which you may see as telma-H. So you shouldn't take note of those differences. So if you're just using losartan on its own, that's 50 to 100 milligrams orally once a day. If it's telmisartan, it's a much lower dose, 20 to 40 milligrams orally once a day. You should master these things for at least 4 weeks. So you can only increase after 4 weeks. Then you can increase as necessary until you reach 80 milligrams orally once a day. So you do not exceed 80 milligrams. With losartan, don't exceed 100 milligrams once a day. Then we come to the beta blockers. So these ones are no longer preferred as an initial therapy for hypertensive patients. They are only useful in patients that are younger, those that can't really tolerate the ACE inhibitors or the ARBs, as well as women of childbearing potential. Because remember, ACE inhibitors and ARBs are contraindicated in pregnancy. So these should never be combined with diuretics because they may exacerbate diabetes. These should be avoided in diabetic patients. And so when you want to combine them within another type of drug, we often combine the beta blockers with the calcium channel blockers. And remember, the calcium channel blockers, they shouldn't be working on the heart, because if you combine them with those that work on the heart, which are known as the non-cardioselective calcium channel blockers, you may potentially cause significant bradycardia. So you should combine them with only the ones that work on blood vessels, the non-cardioselective calcium channel blockers. Then remember that the beta blockers also are going to be attenuating the sympathetic nervous system by blocking the renin-angiotensin system. Major side effects are going to include bradycardia, bronchospasm, so you should give them with caution in asthmatic patients and in patients with COPDs. cold extremities, fatigue, bad dreams, hallucinations, and you should always monitor the heart rate because they have the potential to cause the patient to be bradycardic. Never uses drugs in patients that are hemodynamically unstable. So these are used in patients that are hemodynamically stable. So these agents actually are useful in patients that have hypertension as well as angina, or those that have hypertension and myocardial infarction. Then what are some of the indications? Coronary heart disease, so post-myocardial infarction or angina, heart failure, so you could use bisoprolol or carvedilol. Hypertension in pregnancy, labetalol is one that's commonly used. I'm glad that I'm actually seeing it being used much more often, and it's actually has become a much more common drug even on the wards. Then contraindications include diabetes, asthma, peripheral vascular disease, heart block, and even unstable heart failure, COPDs. It's contraindicated that you should use beta blockers in those scenarios. So what is the dosage? So atenolol is given at 25 to 100 milligrams orally once a day. So we usually start at around 25 to 50 milligrams orally once a day, and we can increase it when as needed. Then with carvedilol, we start at 12.5 milligrams once a day for the first 2 days. Then we increase by 25 milligrams orally once a day. Then we increase up to 50 milligrams daily. And then we keep increasing the dose at an interval of 2 weeks. And this can be given, if we are exceeding these dosages, we can actually give them as divided doses or as a single dose. In the elderly patients, we usually start off with 12.5 milligrams as initial dose. This may be just enough to control the blood pressure. Then with labetalol, we start off at 100 or 200 milligrams orally once a day. Then we increase at 2-week intervals. So the usual dose is roughly around 200 milligrams twice a day. We can increase it up to 800 milligrams in 2 divided doses, so 400 milligrams in the morning, 400 milligrams at the evening, to be taken, of course, with food. And then higher doses can be divided into 3 or even 4 equal divided doses. For example, if you're supposed to get 800 milligrams, you can divide it into 4 doses, where someone will be receiving 200 milligrams at specific intervals 4 times in a day. Then the maximum dose is 2,400 per day. Don't exceed that level. In the elderly, we usually start at 50 milligrams, a much lower dose, 50 milligrams orally twice a day, and we can increase it at intervals of 2 weeks. Also, the maximum shouldn't exceed 2.4 grams in a day. Then we'll come to calcium channel blockers. These reduce the blood pressure by causing arteriolar vasodilatation, and they also reduce the cardiac contractility. Those are drugs like verapamil and diltiazem. Drugs that we commonly use on the wards are the ones that just work on the blood vessels, pretty much amlodipine and nifedipine. Those are the ones I'm going to discuss here. So these are quite useful, especially in patients that have concomitant ischemic heart disease. And the major side effect is mostly seen with headaches, very common with nifedipine, sweating, swelling of the ankles, palpitations, which is due to the rebound tachycardia. Then you may also get some flushing. Indications include those that are above the age of 55 years. They work very well in Black individuals. They are also indicated in angina. Contraindications include bradycardia, especially with those that are cardioselective, heart block, heart failure, as well as use with beta blockers, like I already mentioned earlier on. 2 common drugs we use is nifedipine, usually the long-acting, 20 to 90 milligrams orally daily. Usually our start dose is roughly around 20 milligrams once a day. Then we can increase to 20 milligrams twice a day. Then we can sometimes even start at 40 milligrams once a day. Then amlodipine usually start at 5 milligrams to 10 milligrams, so 5 milligrams once a day or 10 milligrams once a day. Or we can give 5 milligrams twice a day. But usually it's better to give it as once a day in the evening. Then we'll come to the diuretics. So here the most common that I've seen is the thiazide diuretics, and usually we don't give them on their own. They're usually combined with either another class of diuretic or they're combined with another class of antihypertensives. So usually the thiazide diuretics in low dose are a well-established agent, and they actually reduce the risk of stroke in hypertensive patients. But they do have some side effects such as increase in cholesterol, impaired glucose tolerance, hyperuricemia that may precipitate gout, as well as hypokalemia. Then the loop diuretics do have a quite hypotensive effect, and they are not really routinely used for management of primary hypertension. We sometimes do use the potassium-sparing diuretics, but we don't use them as monotherapy. We only use them in the treatment of patients that have hypertension and hypokalemia with primary hyperaldosteronemia. Often they are combined with other drugs. Then, of course, we should monitor the electrolytes, especially when using the thiazide diuretics. So indications include patients above the age of 55 years, Black patients, heart failure, stroke, secondary prevention, heart failure, and renal dysfunction. Contraindications include gout, diabetes, hypokalemia. Then the drugs that we usually give, hydrochlorothiazide, which is often, like I said, combined with other drugs. It can be combined with amiloride, which is the so-called more diuretic, that's the drug. That's the brand. Or it can be combined with losartan, that's the losarkine. You can get a combination of 50, 20, 12.5, then 100 to 25, or 100 to 12.5. So 50 milligrams of losartan, 25.5 milligrams of hydrochlorothiazide, 100 milligrams of losartan, 25 milligrams of hydrochlorothiazide, 100 milligrams of losartan, 12.5 milligrams of hydrochlorothiazide. Or you may have Telma H, which is a combination of telmisartan and hydrochlorothiazide, which can be in 80 milligrams to 25, or 80 milligrams to 12.5, or 40 milligrams to 12.5. And of course, spironolactone, 25 milligrams orally once a day, is often given as an adjunct to patients that have resistant hypertension. So what's our step approach? So generally, there are 4 main steps. Usually most patients are going to be at step 2. It's only a few that I've seen that are at step 1 just on a single drug agent and it's well controlled, but most patients are at step 2. So step 1, so the letters I've already explained what they are. So A for ACE inhibitors or angiotensin receptor blockers, B for beta blockers, C for calcium channel blockers, D for diuretics. So for step 1, we start with a single drug. We can either start a patient on an ACE inhibitor, an angiotensin receptor blocker, a calcium channel blocker, or a diuretic. So if they are younger than the age of 55, we often start them on an ACE inhibitor. That's if they are white or they are Caucasian, and these tend to have high levels of renin in their body. Even the older patients, we start them on an ACE inhibitors. Black patients usually have low levels of renin, so they don't respond so well to the ACE inhibitors unless if they're combined with diuretics. Then if they're not able to tolerate the ACE inhibitors, we can actually substitute with an angiotensin receptor blocker. Alternatively, if they are 55 years older or they are Black individuals of any age, we usually start them on either a calcium channel blocker, which is a non-cardioselective one, and a diuretic. If we have reached the maximum dosage of these drugs and we're not achieving our target blood pressure, then we can combine the drugs. We can combine the ACE inhibitor plus a calcium channel blocker, or we can combine the ACE inhibitor plus a diuretic. Then, if this isn't working, then we combine the 3 drugs, an ACE inhibitor, a calcium channel blocker, and a diuretic is step 3. So some patients are at step 3, the majority of patients are at step 2. Then if this still isn't working, despite the patient actually taking the drugs as they should, the same time every single day, and you have reached the maximum or the ceiling dose of the drug, then we can add another drug like spironolactone, a beta blocker, or an alpha channel blocker to the regimen. That's going to be your step 4. And then if the blood pressure remains elevated despite the maximum dosage of the first drug, add another drug, then titrate it to its maximum dosage, and that's how we keep adding drugs according to steps. So remember, calcium channel blockers like nifedipine and amlodipine, they're very good in Africans, a very good start for patients that have high blood pressure. Even in hypertensive urgency, very good start to use these drugs. For patients with diabetes, congestive heart failure, those that have normal or stable creatinine levels, and those that have hypertension as a comorbidity, ACE inhibitors are very good. So those are the best first line. Then those that have coronary artery disease, beta blockers are the first line because they do reduce the risk of death. Then for most patients that are on antihypertensives, they usually take about 2 to 4 weeks to reach their maximum effect. So we often want to wait for at least a month before we increase the dosage of the medicine or before we increase or add another drug. We usually wait at least 2 weeks to about 4 weeks, so at least a month before you increase the dosage or decide to add another drug. So the patient can just go home and then come back 2 days later, then you add another drug. It can only happen if their BPs are significantly elevated and they are at risk of stroking out or at risk of developing any other complication. That's when we can actually add the second drug. But otherwise, if their BPs are showing a slow trend coming down, give the drug some time before deciding to add another drug. And make sure that the patient is taking the drugs and they are compliant to the drugs. So, step 1. Let me give you examples. So, step 1, you have 3 options. You can either start off with an ACE inhibitor, a calcium channel blocker, or a diuretic. So, if you start with a diuretic, amiloride and hydrochlorothiazide 5 to 50, that's more diuretic, once a day, or hydrochlorothiazide 25 milligrams orally once a day, and spironolactone 25 to 50 milligrams twice a day, or you can give it 25 milligrams once a day. Sometimes you can even increase up to 4 times a day. Or option 2, a calcium channel blocker, nifedipine, long-acting 20 milligrams twice a day, or amlodipine 2.5 to 10 milligrams once a day. Or you can start them with an angiotensin receptor blocker. Usually start off with enalapril 2.5 to even as far as 40 milligrams orally once a day. And those that can really tolerate this, we give them losartan 50 milligrams to 100 milligrams once a day, or telmisartan 20 to 40 milligrams once a day. In step 2, we now begin to combine the drugs. So a diuretic can be combined with an ACE inhibitor, so hydrochlorothiazide and enalapril in those dosage. A calcium channel blocker plus ACE inhibitor, amlodipine plus enalapril, or you can have a calcium channel blocker and a diuretic, but that's not really a common combination. So you can use your losakind, or you can use your Telma H, which I've already talked about. Then step 3, we combine a diuretic, an ACE inhibitor, as well as a calcium channel blocker. In step 4, if it's not controlled, you can add an alpha channel blocker like prazosin 0.5 milligrams twice a day or 3 times a day. Initially at bedtime to avoid postural hypertension, then we increase by 1 to 3 milligrams twice a day or 3 times a day after 3 to 7 days to a maximum of 20 milligrams a day. We can also add a beta blocker like atenolol 50 to 100 milligrams orally once a day, or propranolol 40 to 80 milligrams twice a day or 3 times a day, or hydralazine, which is not commonly used as a management of hypertension. I really hope you enjoyed this video on hypertension. If you did, please subscribe. And if you want me to teach also about hypertensive emergencies and urgency, please comment in the section below. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.